Allow me to introduce a friend of the Academy and someone who's been here before, Dr. Mohamed, who has so many credentials that I am sometimes uncertain of how to introduce him, except he's the guru that does everything that we can't or don't know how to do as a dentist. He's a speech pathologist. He's an oral facial myologist. He has all kinds of accreditations, and he's such a sweet man who wants to help us help our patients get better. So tonight's topic, hypersensitive gag reflex and tongue tie. Allow me to bring back to the stage Dr. Mohamed, PhD. It's all yours, sir.
All right. Thank you so much, everybody, for coming tonight and listen to my presentation. And actually, this is something that because I'm a speech and language pathologist and specialized in more in feeding and dysphagia and swallowing, and also an orofacial myofunctional therapist. I have a lot of toddlers and babies that they come to my clinic and they have issues with their swallowing and vomiting and gagging. And then I started to follow this thing, and I try to my best to figure out. So I just want people to understand that I am not talking about gag reflex, because most of the people, they have gag reflex. What I'm talking about is the hypersensitive gag reflex that actually cause problems. These problems we are going to talk about, like soon. So one of uh, uh, the tongue tie, ankyloglossia, the medical term for it, is present, as you know, at birth, restrict tongue range of motion, may affect breastfeeding, and also may affect the way a person eats, swallow, speaks, and also might affect how the person breathes. And I'm going to talk about that in, like in a minute. It is not there. As you know, the genetic causes of the tongue tie has been reported as X-linked cleft palate syndrome, or a gene mutation on TBX22 causes this as well. The frequency seems to be higher in males than females. And most cases believed to be sporadic rather than genetic. And it is isolated anomaly, although association with other genetic disorders, and might come with cleft lip and palate as well. So typically the lingual frenum separates before birth, as you all know. In this case, it remains attached to the bottom of the tongue or the floor of the mouth. Causes are largely unknown, although some cases have been associated with genetic factors, as we, like mentioned earlier. It affects breastfeeding, complications, speech difficulties, poor oral hygiene, and other oral activities. For breastfeeding symptoms, and I always work with lactation consultants as well. So it prolonged the feeding, because also some people that they come to me and said, oh, she doesn't have any problem with the bottle feeding. And that is actually true, because the bottle feeding and breastfeeding are completely different mechanisms. So they could easily have a bottle and just have latch from a bottle, but it is very difficult for them to latch from the breast, and it is so irritable while they are feeding because there is a problem with lifting the tongue and pressing on the nipple against the hard palate and start latching. And then they're trying to do it in very different ways, which results on the pain in the nipples. And if you see women that they breastfeed their babies, and their babies has tongue ties, they're always irritable, red, and they have a lot of issues. And it is painful. It's really painful if like you hear them talking about it. For the speech symptoms, a disagreement among health professionals, decreased tongue mobility and articulation movement, may have difficulty with sound that need the lift of the tongue, and that is the L, the T, the D, the N, the R, the S, as TH, and sh sounds. So always have issues with these sounds. And there's some, like disagreement until recently, like I should say that, but, like for the last 2-3 years, I have seen a lot of speech pathologists that they were arguing that tongue ties does not affect speech. Now they come around and they start, feeling like, yes, it does. Difficult to predict which patients will have articulation errors or whether this association exists. And I can talk about that because sometimes some patients, they have severe tongue tie, but they don't have any articulation problem. And when people ask me why that is happening, I said, not because the tongue tie doesn't affect them, but because they are overcompensating, and actually they are a perfectionist people. They don't want to, like other people to, like kids to laugh at them at school, have perfectionist parents, and they are really, like, but they are compensating. And that is why, like I was working with this lady, she's 40 something years old. And she told me that I never had any speech problem. Then I told her, yes, you are compensating. And I bet you are exhausted by 4:30, 5 o'clock in the evening. You are so tired. And she looked at me and she said, you nailed it. But I didn't know why I always tired by 4 and 5. I said, because since you get up and from your bed in the morning, you are working against your system just to compensate. And then by the end of the day, you are done. You are exhausted. So because you don't see speech problems or articulation problems with some people that they have tongue ties, that doesn't mean the tongue tie does not affect their speech. I hope I try to make this as clear as possible. Uh, also difficulty with eating food, become picky eaters. Licking food, such as like ice cream, is very difficult for them because they can't stick out their tongue. Difficulty playing wind instruments, orthodontic problems, open bite and malocclusion, self-esteem, and psychological issues. Difficulty eating, and I don't know if you follow, because that's one of the questions that I ask when they come for like for their consultation sessions. I said, is he or she is a messy eater? And most of the time, the answer is yes. Do they always try to, like lick their lips so they could, like clean food from the corners of their mouths? And they said yes. And sometimes they're picky eaters because any food that has textures that make them gag, and actually they vomit and project all the food. I have also found that there is difficulty with playing wind instruments such as the saxophone. They have to compensate by moving, like their head, or try to bite, sometimes in, like with some kind of protrusion of the mandible. And if you are doing that for a very long time, that definitely is gonna affect your temporomandibular joint, and then you're gonna have a TMD issues, excuse me, later in the future. We have found that, like that, like most of kids that they have tongue ties, they have a tongue thrust, and their tongue thrust because the issue is their tongue is always resting on the floor of the mouth. They cannot rest it on the roof because of that tongue tie, because it is attached to the floor of the mouth. So everything is coming forward. So imagine that if we swallow between 700, 800 to 1,000 times a day, which is the average is 900 between food, fluids, and saliva. And every time you swallow, you keep pushing against your teeth with your tongue, which you all know that is one of the most strongest muscles that we have in our body. That definitely is gonna cause an issue with your teeth. And sometimes if you don't eat neatly, and you have saliva coming out, and you have reduced oral sensitivity, and that might cause self-esteem when you are in school, like among other kids. And because kids actually nowadays, they're always vicious, and they are not forgiving at all. So they are not gonna allow something like that to happen if you are a messy eater. And if you drool, or, like, so it's gonna affect the person psychologically. So you test it by doing range of motion, and you do that. There is many people that are doing it. Sometimes I am myself with patients when they come and tell me, oh, if the tongue start move, because we do the orofacial myofunctional exercises, and sometimes the tongue becomes so functional, even with the presence of the tongue tie. And they asked me, do we need still to take it off? And I said, I am with taking it off. You have to go and release it. And because of other issues, the neck pain, and like, and headaches, and so forth. It's not just about the articulation or ortho. It is also about the breathing, because you need to bring your tongue up to open your airway, so you can become a nose breather instead of like a mouth breather. And that's when we work with like people that they have sleep apnea, like in my clinic. And when we work with them on, like to release the tongue tie, and then work on the exercises to lift the tongue up, and teaching them how to change their resting posture for the tongue, and swallowing with the tongue, back instead of forward. That also affect, like a lot their sleep apnea. And we have people reporting to us that they sleep with their kids started sleeping, for example, with their lips closed, and then they're breathing, they get um, up in the morning and they're not tired like before. So we have seen that a lot. Um, as I said, like the more severe tongue tie you have, the more difficulty with your speech, that you're gonna have, because the tongue is not moving the way it should be. Um, um, the gag reflex, like it is involuntary reflex involving bilateral pharyngeal muscles, contractions, and elevation of the soft palate. And the soft palate, all the soft palate, you know, you are doctors. And then in that area between the soft palate and the hard palate, there is a muscle that goes into the tongue, which is one of the extrinsic muscles of the tongue, which is the palatoglossus muscle. And that the only muscles that innervated by the vagus, and the rest are innervated by the hypoglossal nerve. There is other branches from other nerves that is still going in, but the main ones that I'm talking about, the vagus and palatoglossus muscle. So, and always evoked by stimulation of the posterior pharyngeal wall, like the tonsillar area or the base of the tongue. And that when you are talking about the normal gaggers, like everybody else that they have, like most of the people, because I think it is 37% of people that they have absent gag reflex. They just don't have a gag reflex. So that's why it is later on, I'm going to talk about the predictions of, death, but when we come to that. So it is essential component of evaluating the medullary brainstem that plays a role in declaration of, brain death, that gag reflex. And uh, sometimes, like natural somatic response in which the body attempts to eliminate unwanted agents, foreign objects from the oral cavity through the muscles contraction at the base of the tongue and the pharyngeal wall. So the I was very funny. I was seeing this patient this morning, 5 years old, and his mom was very concerned because when he brushes his teeth, uh, she said his tongue is always going forward and blocking the area at the back and not allowing, he doesn't, brush his tongue properly, because the tongue becomes so stiff. And when I looked down, I found out that actually he has a tongue tie. And this was actually this morning. And funny enough, uh, his dad is a family physician. So, so when I was talking to her, I said, oh, his dad is a doctor, and how come he didn't find that out? Uh, so anyway, and in the first few months of life, and this is very interesting, because sometimes when you try to connect the dots, and figure out why things happen, and try to connect the dots, I laugh, because things are very intertwined and very um, connected to each other. I'm going to talk about it. In the first few months of life, it is triggered by any food that the nucleus trackers, in the region of the brainstem, deems too large or too solid for a baby to digest. So it always try to, because the baby is not gonna digest that solid food. So the system works to prevent any solid food from going on, to swallow. And that is between around 6 to 7 months, the reflex diminishes or start to reduce, allowing infants to swallow more solid food. That is exactly the time when these babies change their swallow from the infantile swallow to an adult swallow. And instead of swallowing with, like like forward up to 6 months, by 6 to 7 months, they start going to swallow with the tongue back, not forward, to an adult swallow from, like having an infantile swallow. And actually that happens around the same time. So, like it's just very, like when you think about it, why, like everything is just connected. Am I doing okay so far, guys?
You're doing great. Carry on, Mohammed.
All right. Okay. So the pharyngeal reflex development, it is mediated by the glossopharyngeal nerve, the vagus nerve, the glossopharyngeal provides motor, like sensory information to your mouth and the throat, help to raise part of the throat, enabling swallowing. And then you have the vagus nerve is associated with the, like the third of the pharyngeal arch, uh, and with the cranial nerve 5, that they all work in that, like, and 6 pharyngeal arches. They all work together in that area. I don't want to get into that. The main thing that I concerned when I come to the tongue, I concerned about two cranial nerves, which is the hypoglossal, the 12th, and the vagus nerve, because that are really the main cranial nerve that they go to the tongue. And there is, like the pharyngeal reflex, the mechanism or classifying, either is, somogenic, follows direct physical contact with the trigger area, or psychogenic, and that is sometimes just by mental trigger, like you see somebody vomiting or smelling on, and then you start gagging, like, but like again, I want to bring it to your attention. This is not what this lecture is about. This is not what I'm talking about. Um, the I want people to understand that I'm talking about the hypersensitive gag reflex. Pharyngeal reflex mechanism, sensation to the posterior pharyngeal wall, like at the base of the tongue, act as the afferent limb of the reflex to the ipsilateral nucleus. And in that area of, like the foramen, we have like 3 foramens on the, like on the, if somebody can correct me, like the incisor prominent, and then we have the 2 at the back on the, where the nerves coming down, where it's on the cranial nerve and the pharyngeal nerve, the facial, I mean, and they're all, most of them are efferent nerves. Also, the stimulation of the soft palate can also elicit the gag reflex, and that could also, like cause an issue, with some people that they have problem with the, like what receive radiation therapy. I have seen it with a lot of people that they have radiation therapy for some reason, and I like a couple of them, 3 or 4 people, they always have that issue. I don't have enough sample to do any research or anything, but I have seen it with people that I have velopharyngeal cancer, and they receive more, they receive radiation. Lack of gag reflex, guys, may be a symptom of a more severe medical condition, like cranial nerve damage or brain death. If you are someone has a gag reflex, because as I said, some people they just don't have it. Hypersensitive gag reflex may be caused by anxiety, post-nasal drip, acid reflux, or oral stimulation such as dental treatment. Lack of gag reflex may be symptoms of more severe. A study of 140 people, 37% were found to have absent gag reflex. And they're normal people. May be higher in patients with history of smoking or tobacco use. That was the research has found. So there is 37% of people that they don't have gag reflex. So if you take that gag reflex, because I do see people coming, like for swallowing and dysphagia, and I always find out that they are on 2 feet just simply because they don't have a gag reflex, which is very bizarre. And then I asked the patient and said, but actually, are you a gagger? I said, no, like I never gag. And then I feel like puzzled, like how you just go ahead and put somebody on a tube feeding and like is stopping them from eating and enjoying the food and put them on tube feed just because they don't have a gag reflex. And actually, most of them, they don't even have a gag at all since they were born. So it has so many issues that goes with gag reflex, and people have to be very careful before they jump to conclusions. It could affect all ages, common in pediatric field that interferes with the ability to complete a thorough oral assessment, makes upgrade advancement of food textures more difficult. I have a patient that he's 9 years old. He comes to me, and because he eats only soft baby food. He's a normal kid, very smart, and he's 9 years old, and he didn't even eat chicken nuggets. And that is just, like something that, to me, to up to 9 years, and nobody's able to, like figure it out. It makes me sick, So it limits the treatment options when related to oral stimulation, should be assessed by specialists, like OMT, SLP feeding specialists for the gag reflex. Children may present with hypersensitive gag reflex for a number of reasons, and this is in the literature, not my topic today. Bilateral lesions of the corticobulbar tracts because of TBI, and I'm laughing because a lot of people, or all people, normal people, if you can say that, they cannot swallow with open mouth. They have, like their mouth is open like that. I don't know if you see me, guys, like I'm trying my best. And swallow is very difficult to swallow with your mouth open, wide open. And because of that reason, all of my TBI patients that they can swallow with their mouth open, which is, like it's very interesting. interruption of autonomic nervous system, and conditioned response, behavioral food aversions, and I have seen that a lot. Surgical alteration of gastrointestinal system, fundo applications, lower esophageal sphincter issues, other gastrointestinal disease. And that is, like they do fundo applications, and that it is a procedures. I don't know if all of you know about it. It is a procedure that they do it for patients that they have issues with their lower esophageal sphincter when it is too loose, and they also do balloon surgery for them as well. This is, like very interesting. In our practice, we follow 23 pediatric patients from 1 year, 3 months to 8 years, something years of age, suffering from severe hypersensitive gag reflex, preventing them from eating solids and different food textures. All children have some degree of tongue tie and were referred for lingual frenectomy. The results, 19 of the 23 children, parents reported that their gag reflex was reduced by at least 50% during the first 2 weeks post-frenectomy. Nearly disappeared after 1 month post-frenectomy, allowing them to start eating regular food textures and normal bite sizes. 3 patients took longer than 1 month before showing improvement, but we are able to have regular textures and gag reflex disappeared by 3 months post-frenectomy. These patients were the oldest of the group. It is 8 years, 2 months, 7 years, 8 months, and 7 years, 6 months. In one patient, 4-year-old girl, no improvement was noted until 3 months post-frenectomy. Complete disappearance of gag reflex or hypersensitive gag reflex was noted 7 months later. For adult patients, we referred only 5 patients for lingual frenectomy. Female, male, 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 and female. And the results, all 5 cases reported their gag reflex disappeared within 2 weeks post-frenectomy, or reported tremendous improvement. Hello?
Mohammed, are you having a problem?
Yeah, no, I'm just, like asking if there's everybody is following me.
Yes, everybody's following you. You're doing a great job. Carry on.
Thank you. So now, based on this primitive data, I came to conclusion. I said, yes, there is, correlation between, hypersensitive gag reflex and tongue tie. But I'm not saying that everybody that has a tongue tie presents with hypersensitive gag reflex. But I'm saying most probably all people that have hypersensitive gag reflex might have some degree of tongue tie. I just want to make that in conclusion. So now Mohammed was thinking, as yes, but why that is happening? Why this is happening. So I was thinking, from the anatomy point of view and from the physiological point of view, and I'm just trying to figure out, like if there is, I believe that there is a connection between, like hypersensitive gag reflex and a tongue tie, why that is happening, you know. So that is happening, like because I'm gonna just go down here and then come back to this. So if we have a tongue tie, then the tongue tie, the web or the curtain is actually attached to the genoglossus muscle. And genoglossus muscle is innervated by the hypoglossal nerve. And the hypoglossal nerve is coming from the medulla oblongata. What that means? The center for the gag reflex is actually the medulla oblongata as well. So what is happening is when you have a tongue tie, then you are sending, like more, like signals to the medulla oblongata, which you also is the center of the hypersensitive gag reflex. When you cut the tie, then the sensation or the signal that is going to the medulla oblongata is going to be less. This is just a suggestive theory. I don't know. I'm just trying to work on this area because there is no literature of the hypersensitive gag reflex and the tongue tie. And this is what I came up with. To me, makes sense. That's why I'm presenting it today to you guys. But if you have any questions about my theory and you can come up with a better theory, I would be more than happy to hear and your theory and your suggestions, because it is the hypersensitive gag reflex is a huge problem, a really huge problem, and it is very well underdiagnosed, underestimated, and we need to pay more attention to it. I do, because I do work maybe for the dental people. You have your patient, you see them, you sedate them, you do your thing, they're gone. For me, they come for feeding, and that's why it is an issue for me, and I always keep thinking about it. And this is my presentation for today, and thank you so much, guys, and for listening. And I hope this is like something that you could like take home and talk about it, and we can all together do a better job. Thank you so much, and I'm here for any questions.